Hello and welcome to our webinar. My name is Barbara O'Brien and I'm one of the maternal fetal medicine attendings and geneticists at Beth Israel Deaconess Medical Center, and I'll be giving the webinar with our senior genetic counselor, Karen Marchand. The title of the webinar is Prenatal Genetic Testing, Updates in the Era of Cell-Free DNA and Expanded Carrier Screening.
We have no financial disclosures. The objectives of this talk are to review the options for prenatal genetic screening, discuss the benefits and pitfalls of using cell-free DNA, review the benefits of the nuchal translucency ultrasound, review the pros and cons of expanded carrier screening, highlight the multiple new ACOG and SMFM statements regarding genetic screening, and describe the current BIDMC CMFM practices with regard to screening. It's well established that approximately 3 to 5% of all pregnancies are affected with a birth defect or genetic condition, and these fall in different categories. The first part of the talk will be addressing how we screen for chromosome abnormalities in pregnancy. That part of the talk will be given by Dr. O'Brien, and then the second part of the talk will address how we screen for single gene disorders in pregnancy, and I will give that portion of the talk.
Okay, so let's start off with describing two cases that by the end of the talk you'll be able to answer. The first case is a case of a 40-year-old Gravida 2 Para 1 who's at 10 weeks and 5 days with a pregnancy complicated by obesity with a BMI of 40. The question is, do you offer cell-free DNA to this patient? Do you send her for an NT ultrasound? So this comes up commonly. The second case is a case of a 21-year-old Gravida 1 at 12 weeks who wants the test that tells you the sex of the baby. Do you offer her cell-free DNA screening, and do you still send her for an NT ultrasound? So two common scenarios that by the end of the talk you'll be able to answer. Just a quick note about terminology. Non-invasive prenatal testing, often referred to as NIPT, is a misnomer because it really includes first trimester screening, integrated screening, quad screening, the NT test. These are all, quote, non-invasive prenatal testing methods. And so we prefer the term cell-free DNA, which is circulating placental DNA that's used for fetal aneuploidy screening. Placental DNA is about equal to fetal DNA, but not always. Cell-free DNA is circulating DNA not contained within a cell. So we prefer the term cell-free DNA over NIPT, and you'll hear me use that throughout the talk. Although not entirely specific to prenatal screening, we'll use the term cell-free DNA. So a myth is that cell-free DNA is not a non-invasive karyotype. So for example, it's not an amnio by blood. Cell-free DNA is a screening test. It's not a perfect test, and therefore has test performance characteristics such as false positives, false negatives, positive predictive value, negative predictive value, and the concept of residual risk. So this slide serves to underscore the fact that there have been an incredible number of committee opinions, consult series, and consensus statements regarding the use of cell-free DNA, microarray, next-generation sequencing, and now whole exome sequencing in prenatal diagnosis that have been published over the last several years. There are 3 different platforms, different products, and different companies that offer cell-free DNA screening in the United States. We happen to use something called a SNP-based platform, which is Natera's Panorama test. This slide looks at the performance of cell-free DNA for aneuploidy. So as you can see, the detection rate for trisomy 21 is excellent at about 98 to 99%. The detection rate for trisomy 18 is also excellent at 96%. Trisomy 13 performs less well, but still very good at 91%. Turner syndrome has a detection rate of about 90%. And then the other sex chromosomal abnormalities grouped have a detection rate of about 93%. We have some data for monochorionic twins, and the data that we do have is good at 93%, but ACOG says that we should not be using cell-free DNA for twins yet because there's not enough data. If you look at the false positive rate, you can see that the false positive rate is extremely low at about 0.1 to 0.2% for all of the aneuploidies that we have the ability to screen for. So cell-free DNA is an excellent test. The myth is that 99% detection rate is equal to 99% accuracy, and that is not correct. Detection rate does not equal accuracy. A high-risk cell-free DNA result does not necessarily mean the fetus is aneuploid. And we can look at this because we can go through what positive predictive value is. So I'm going to go through the positive predictive value of cell-free DNA in a 40-year-old and next in a 21-year-old. So this depends on the prevalence of trisomy 21 or Down syndrome for a woman who is 40 years old, and that is 86, 1 in 86. So the probability that the result is a true positive is 93% in a 40-year-old, and the probability that the test is a false positive in a 40-year-old is 7%. So the positive predictive value of cell-free DNA for a 40-year-old is very good. However, if you look at the positive predictive value for a 21-year-old, it's very poor. Because of the prevalence of Down syndrome in a 21-year-old is only 1,100. So the probability that the result is a true positive in a 21-year-old is only 49%. And the probability that it's a false positive is 51%. So there is a positive predictive value calculator that you can go on at the National Society of Genetic Counselors website or perinatalquality.org that you can actually give the patient the positive predictive value for her particular cell-free DNA result. And I would really encourage you to do that when you get your results. The negative predictive value is the same for both the 41-year-old and the 21-year-old, which is greater than 99%. Positive predictive value decreases with the lower the age because the prevalence decreases as women's age decreases. Okay, so how does cell-free DNA's performance compare to conventional aneuploidy screening on a population basis? And this is a nice table that shows the detection rate for Down syndrome, all other aneuploidies, for first trimester screening, integrated screening, cell-free DNA, as well as invasive testing. And if you look solely at the detection rate for Down syndrome, you can clearly see that cell-free DNA is the best test for Down syndrome, with sequential and integrated screening being very good and first trimester screening also being a good test, detecting 80% of women with Down syndrome. However, if you look at the detection rate for all aneuploidies, you can see that cell-free DNA is not the best test for detecting all aneuploidies. In fact, sequential and integrated is the better test if you want to detect all aneuploidies. Obviously, invasive testing with CVS or amniocentesis is the best test, but for non-invasive testing, cell-free DNA is not the best test to detect all aneuploidies. This Choosing Wisely was published by the Society of Maternal Fetal Medicine. This happens to be back from 2014, and it says to not make irreversible decisions based on the results of this screening test. And you can see when we went through the scenario for a positive predictive value that in a 21-year-old, the positive predictive value was only 49%. So again, invasive testing is always encouraged when you get a positive cell-free DNA test. The Don't Offer Invasive Prenatal Testing to Low-Risk Patients, this was published back in 2014, and ACOG has softened its opinion on that, and we'll go through this a little bit more detail in a couple of minutes. So in 2012, Mary Norton published a study that looked at a large cohort of patients who had early risk assessment and then who had an abnormal early risk assessment and then had their karyotypes performed. And 27% had significant abnormal karyotypes that were other than trisomy 13, 18, and 21. So what this tells us is that cell-free DNA may not be the best test for all women, especially low-risk women, because the cell-free DNA may have missed these karyotypes if cell-free DNA was performed. Let's go through some limitations of cell-free DNA. There can be false positives. So remember, cell-free DNA is actually derived from placental DNA. So that's a very, very important point. So it's almost like a CVS as opposed to an amniocentesis. It's placental DNA. So you can have confined placental mosaicism, which is where the placenta is, part of the placenta is abnormal and the fetus is actually normal. And this is higher in cases of trisomy 18, trisomy 13, and the sex chromosomal aneuploidies. You could have maternal cell-free DNA abnormalities, such as a maternal sex aneuploidy, so a woman who has Turner syndrome, mosaicism, or some other form of mosaicism. You can have a false positive cell-free DNA in women who have fibroids, in women who have malignancies. And you can also have false positive cell-free DNA results in women who have had vanishing twins. One twin could be aneuploid and still be releasing abnormal cell-free DNA into the maternal circulation. So these are all reasons to have false positive cell-free DNA. There's also this concept of no-call results. And so you may have a patient who gets a no-call result. And this is present in about 1 to 8% of certain cases with certain companies. And this may be due to something called a low fetal fraction, or the circulating amount of cell-free DNA in the maternal blood is too low in order to get a result. You need about 3 to 4% of circulating cell-free DNA in order to obtain a result. This is more frequent in women who are obese, more frequent in patients who have their blood drawn at an earlier gestational age. Also more frequent in fetuses who are aneuploidy, so fetuses who have trisomy 18 and triploidy. Also more frequent in maternal states of high cell turnover. These are all more likely to have no-call results. So there's a committee opinion that was published in 2015 that reminds us of a few key points. Conventional screening, such as ERA or sequential screening, remains the first line for most women. Routine screening of copy number variants, such as duplications and deletions using cell-free DNA, is not recommended. Comprehensive chromosomal testing should be done with amniocentesis. A second trimester anatomy ultrasound should be performed with cell-free DNA. So you should always get an anatomical survey when you're doing cell-free DNA. And an abnormal cell-free DNA result should be confirmed by CVS or amniocentesis. You should never act on an abnormal cell-free DNA result alone. So pre-test and post-test counseling is very important with cell-free DNA. And this is a nice checklist that was published by SMFM to remind us of all the things that we need to talk about to patients before we draw their cell-free DNA. We need to remind them that it is the best test for trisomy 21. It does not screen for all chromosome abnormalities. It just screens for chromosomes 13, 18, 21, and the sex chromosome abnormalities. Women who desire definitive information about chromosome conditions in their pregnancy should be offered the option of invasive testing. There are false positives and false negatives that do occur with cell-free. Diagnostic confirmation with CVS or amniocentesis is recommended for women who have an abnormal result. A negative cell-free DNA result indicates a decreased risk, but does not definitely rule out trisomy 21 or the other chromosome conditions that the test screens for. And all genetic screening is elective. Women don't have to choose aneuploidy screening. So I find this really a nice checklist when I have to run into a room and quickly consent somebody for cell-free. Okay, so now let's switch gears to talk about nucleotranslucency ultrasound and the pitfalls for this. Nucleotranslucency, as we all know, is part of the first trimester analyte screening. So if we're having cell-free DNA screening, why do we need an NT ultrasound, and do we need an NT ultrasound? There was a really beautifully well done study by Mary Norton in 2014 that looked at the California prenatal screening program from 2009 to 2012. There was over 1 million women in it who had conventional biochemical screening, 5.2% screened positive, and about 26,000 had diagnostic testing with either a CVS or amniocentesis. Almost 3,000 had aneuploidy. 17% would have been missed if they got cell-free DNA alone, and this is in the low-risk population. So the take-home message for this is that in the low-risk population, really early risk assessment is the best test because it can detect other chromosome abnormalities that is not screened for by cell-free DNA. So biochemical-based aneuploidy screening is still recommended in low-risk population as average age women. It screens for a wider variety of chromosome abnormalities. For younger women, the proportion of aneuploidies that are trisomy 13, 18, 21, and the sex chromosomal abnormalities is less than the advanced maternal age population. It can also, ERA can also be used as a risk assessment for multiples. Early risk assessment also gives us information on PAP-A, which is a screening tool for placental insufficiency. ERA is a cheaper test, and you can argue that there's less genetic counseling required in the case of ERA than cell-free. There was another very important practice bulletin published in 2016 called Screening for Fetal Aneuploidy, that obviously all women should be offered aneuploidy screening regardless of age. No one test is superior to other screening tests in all test characteristics. They all have their benefits and pitfalls. No screening method is a substitute for an anatomic survey, so all women should be offered anatomic survey, and all women should be offered diagnostic testing. The important point that came out of this bulletin is that parallel simultaneous screening is not recommended. So, for instance, what this means is that you shouldn't order an ERA, for instance, and cell-free at the same time. Pre and post counseling is recommended for cell-free DNA, like we had talked about before. Conventional screening methods, so ERA or sequential screening or whatever serum screening that you use in your office, remains the first line for most women. And routine screening for copy number variants, duplications, and deletions using cell-free DNA is not recommended at this time. Second trimester ultrasound should be performed with cell-free DNA, and abnormal results should be confirmed by CS or amnio. Okay, the question that comes up often in our office and probably in your office as well is, what if my 31-year-old still wants, quote, the gender test? What do you do? Well, you talk to her about all the screening options available to everybody. She must understand what the test does and does not screen for. You have to explain to her that she may have a large out-of-pocket expense depending on her insurance, maybe hundreds of dollars depending on her insurance. And you include the pre-test counseling lists that we had gone through before. So she can have the test, but she must understand that it's our recommendation that the early risk assessment is the better test for her, and that it can probably screen for other chromosome abnormalities better than the cell-free DNA test in her age group. If my patient had low-risk cell-free DNA, should I still order the first trimester ultrasound, and when should I order it? So this is an example of some images of the first trimester genetic ultrasound. And you can see in the top, let's see if I have a pointer. In A, you can see that we can see parts of the brain very well. In B, you can see that we can see the nasal bone and the profile. In C, you can see that we can see a four-chamber heart. D, you can see a stomach, and so forth and so on. I won't go through all the images, but you can see that we can see a lot of the anatomy in a first trimester genetic ultrasound, and we can detect many birth defects. The optimal time for an detection of anomalies in the first trimester appears to be in week 13. Why do an NT ultrasound when you did cell-free DNA? What does it matter? Well, it increases the detection of chromosome anomalies not screened for on cell-free DNA. So again, cell-free DNA only screens for chromosomes 13, 18, 21, and the sex chromosome abnormalities. If you have a first trimester ultrasound with a nuchal translucency, you can screen for other chromosome abnormalities as well as genetic abnormalities if the NT is abnormal. So if the MT measurement is abnormal, we offer genetic counseling, we offer diagnostic testing to screen for other chromosome abnormalities and genetic syndromes that the cell-free DNA can miss. And we offer an early anatomic survey. You can often diagnose an early demise with a first trimester anatomy survey and NT ultrasound. We don't want to miss twins, and we want to get accurate gestational ages. So about half of all anomalies detectable by ultrasound can be identified in the first trimester. And the ideal timing for the first trimester structural scan is 13 to 14 weeks. So the SMFM consult series put out an important guideline looking at the role of ultrasound in women who undergo cell-free DNA screening, looking at this very point. And they state that women who already have had low-risk screening via cell-free DNA, you don't need an NT per se, but they do recommend an 11 to 14-week ultrasound, and that would include an NT. So it's really a first trimester genetic ultrasound. All women with structural fetal anomalies should be offered diagnostic testing with chromosome microarray as well. So there's a lot of information we can get from a chromosomal microarray. So what do we do here at BIDMC in the Center for Maternal Fetal Medicine? In our low-risk practice, we offer the early risk assessment combined screen as our primary screen for low-risk patients. If patients request the cell-free DNA, they're counseled on the limitations of the test and the potential out-of-pocket costs. In high-risk patients, advanced maternal age patients, patients who have abnormal ultrasound screenings or family history, they're offered cell-free DNA as the primary screen. All patients, including low-risk patients and high-risk patients, get a, quote, NT first trimester anatomy survey. So that includes an NT as well as looking at all the anatomy in the first trimester. And they're offered diagnostic testing for comprehensive chromosome abnormalities if an abnormality is found. And they also get a detailed anatomic survey between 18 and 20 weeks gestation. So just to review the ACOG SMF statements on universal cell-free DNA screening that was published back in 2015 and 16. Cell-free DNA is not the appropriate choice for first-line screening due to lack of cost-effectiveness and limitations. High-risk patients are the optimal candidates for routine cell-free DNA screening. Women who desire comprehensive testing should be offered diagnostic testing. Cell-free DNA aneuploidy screening requires very careful pre-test consent and formal post-test counseling for abnormal results. And as mentioned before, simultaneous cell-free DNA and other aneuploidy screening methods is not recommended. I think I went through this before, so I won't go through this again. So I'm going to skip that. And now you can answer these two cases. So case number one, in the case of a 40-year-old gravida 2 para 1 who's 10 weeks with a pregnancy complicated by obesity and a BMI of 40, do you offer her cell-free DNA screening? The answer is yes. You do have to counsel her that the cell-free DNA may come back with a no result because of her BMI. So she may ultimately need an early risk assessment as her screen. Do you still send her for an NT ultrasound? And the answer would be, it would be an NT ultrasound / genetic first trimester ultrasound. Case two, in the case of a 21-year-old who wants to know the sex of the baby, do you offer her cell-free DNA screening? The answer would be yes, but you would counsel her on the limitations of cell-free DNA screening in this setting and the benefits of an early risk assessment over cell-free. Do you still send her for an NT ultrasound? And the answer would be, it would be an NT ultrasound as well as a first trimester ultrasound. So now I'm going to turn the talk over to Karen Marchand, and we'll take questions at the end.
Okay, so now we're going to switch gears and talk about screening for single gene disorders in pregnancy. Certainly, some screening for single gene disorders occurs through routine ultrasound assessments. However, it's also standard practice to use carrier screening to attempt to identify couples who are at increased risk to have a pregnancy affected by a single gene disorder. We are each predicted to be a carrier of approximately 2 to 5 different inherited conditions. Primarily, these conditions follow an autosomal recessive inheritance pattern, which is demonstrated in the pedigree on the left. In this pedigree, you can see 2 affected individuals who are shaded in, who have parents who are carriers, indicated as half shaded. You can also see how easily carrier status can be passed unknowingly through several generations of a family. Classic examples of autosomal recessive inheritance are cystic fibrosis, Tay-Sachs disease, and sickle cell disease. Women may also be carriers of X-linked conditions, which is demonstrated in the pedigree on the right. In this pedigree, you can see shaded males who are affected and carrier females. For some X-linked conditions, females who have an altered copy of the gene may also have some symptoms, though generally to a less severe degree. Classic examples of X-linked inheritance are Duchenne muscular dystrophy and Fragile X syndrome. Carrier screening using gene analysis has 2 forms, genotyping and gene sequencing. Historically, carrier screening was accomplished through genotyping. Genotyping involves looking directly for only the most common changes within a gene. Typically, these assays assess for the presence of founder mutations or mutations that are common in specific ethnic groups. More recently, gene sequencing has been used for carrier screening, and this involves reading through the entire coding sequence of a gene. Any variation from the reference sequence is classified as either being a benign change, a pathogenic or disease-causing change indicating carrier status, or a variant having uncertain significance. Next-generation sequencing, abbreviated NGS, involves assembling the sequence of a gene from sequencing of multiple overlapping fragments. This can be performed for a single gene or for multiple genes at the same time. This technique began gaining in popularity approximately 10 years ago and allowed for expanded carrier screening to come on the market. Expanded carrier screening, these are single tests that can screen for hundreds of diseases simultaneously. And these tests have both pros and cons as compared to conventional genotyping type of screening. The pros are that they are cost effective. So these tests cost in the hundreds generally for patients as opposed to the thousands potentially for out-of-pocket screening for diseases individually. They have much higher sensitivity because they use a sequencing platform. So the residual risk is much lower after negative screening, and the detection rates are higher. We are able to use pan-ethnic panels, so we are able to assemble lists of diseases where a single test can be used for patients having all ethnic backgrounds. This simplifies the process for offices and providers. To have more information allows for more informed decision-making on the part of the families. And these types of tests allowed you to have all of your carrier screening results for a patient on one report rather than needing to access different parts of the online medical record to find the different carrier screens that were performed. These tests do also have some cons. Some of the conditions included have variable phenotypes. They may have a severe childhood onset phenotype as well as more mild adult onset phenotypes. In a sequencing strategy, you will identify the more mild phenotypes as well as the severe, where with a genotyping strategy, you would identify only the severe phenotype. Some of the lists of diseases that the labs have assembled include very mild conditions that may result in patient anxiety rather than be of benefit. These tests are associated with higher levels of patient anxiety just given the higher detection rates. So for some of the larger panels, those having more than 200 conditions, for instance, there's some data to suggest that about 45% of patients may be identified as a carrier of at least one of the included conditions. And there is the possibility of incidental findings. So for some of the included conditions, to be a carrier may also imply some health risk for the patient, for instance, an increased risk for cancer. Back in March of 2017, the American College of OBGYN published 2 different committee opinions addressing carrier screening. These are committee opinions 690 and 691. Opinion 691 was basically just an update on prior opinions addressing what is the sort of minimum basic screening that providers should be offering, whereas opinion 690 was brand new and really more related to how should we handle these new expanded carrier screenings and these new technologies in our practice. And I'll go through some of the key points of both of these opinions. So Committee Opinion 690 weighed in on what would be the most appropriate strategy and actually stated that there isn't a most appropriate strategy. So they state that ethnic-specific, pan-ethnic, and expanded carrier screening are all acceptable strategies for pre-pregnancy and prenatal carrier screening, and really leave it up to each provider or practice to establish what their standard approach will be. Determination of an appropriate screening for any given patient shouldn't be just specified by what one practice decides is the list of conditions, but rather based on their own family history and personal values after counseling. Screening should be optional. Patients should feel comfortable declining any and all carrier screening offered. Certainly some patients feel the information would be more of a burden than a help to them in pregnancy. And that if a patient requests a different strategy than that the office has decided upon, that testing should be made available after discussion of benefits, limitations, and alternatives. Opinion 691 states that all patients should be offered at minimum carrier screening for spinal muscular atrophy, cystic fibrosis, and hemoglobinopathies, including use of a complete blood count. Some patients should be offered additional screening as well. So any patient with a family history of Fragile X syndrome or intellectual disability or autism suggestive of Fragile X syndrome, or any patient who has premature ovarian failure should be offered carrier screening for Fragile X. Individuals who have Ashkenazi Jewish ancestry should be offered additional screening for those conditions that have higher frequency in that population. And then individuals who are consanguineous with their partner or blood relatives should be offered genetic counseling and likely some expanded carrier screening. And genetic counseling would also be indicated for any patient who reports family history concerns. The goal of expanded carrier screening should not necessarily be to identify as many carriers as possible in a population, but rather to provide a balance between identifying carriers of the more common conditions, but at the same time minimizing anxiety associated with identifying carriers of extremely rare conditions. The American College of OBGYN does specify some guidelines for what types of conditions should be included in an expanded carrier screening panel. And they state that these conditions should have a carrier frequency of at least 1 in 100, and I would argue that even that is a little bit low in frequency. They should have a well-defined phenotype, have a detrimental effect on quality of life, and should be able to be diagnosed prenatally, which any genetic condition which has an identified gene change is able to be diagnosed prenatally. This was a timely story on NPR just this week. Prenatal testing can ease minds or heighten anxieties, and sometimes it does both at the same time. This story is about a couple in California who misunderstood their carrier screening results and actually thought that their pregnancy was at 25% risk for spinal muscular atrophy, when in fact the risk was lower. And this happens frequently, that carrier screening is done in an attempt to gain peace of mind, but often can actually cause anxiety for the family. And there's some data to suggest that anxiety always remains present to some extent even after subsequent reassuring results. So even after a partner is determined to have low risk for the condition, some residual anxiety may remain for that family. And our goal with screening, we really need to consider minimizing the potential harm. So we want to really carefully consider the number of conditions in addition to the nature of the conditions. And ACOG states that although predefined panels are marketed by commercial labs, each has a set of different panels that they offer, that healthcare providers should carefully evaluate the conditions included and determine the appropriateness of the panels, that not the largest panel offered is not necessarily the best, and that even some of the smaller panels may include conditions that may not be in a patient's best interest to screen for. As an alternative, some providers might choose to work with companies to create custom panels to suit their practice. And at Beth Israel, we have chosen to work only with companies that do allow us that customization. And we actually, in the last year, did develop ourselves a custom panel of approximately 20 conditions that we felt were conditions many families would want to know about and that are fairly common in the population. So this panel includes about 11 of the more common Ashkenazi Jewish conditions. It includes screening for alpha thalassemia and beta globinopathy. So these are conditions like beta thalassemia or sickle cell disease. It includes a couple conditions that are pan-ethnic and fairly frequent, so autosomal recessive polycystic kidney disease, cystic fibrosis, spinal muscular atrophy, Smith-Lemli-Opitz syndrome, and also includes Pompe disease, which is more common in the African American population, and two X-linked conditions, Fragile X syndrome and Duchenne muscular dystrophy. The process of ordering expanded carrier screening for anyone who hasn't ordered this within their practice already, we like to provide patients with an information sheet, ideally prior to the first prenatal visit in a packet that's mailed to them prior to the visit. So that they have some background information prior to being asked whether they want this screening performed. And we're going to also work on identifying some good online resources for information for patients as well. Informed consent needs to occur at the testing visit. In the state of Massachusetts, written informed consent is legally required for any genetic testing. Here, we usually will have the patients sign the lab informed consent as well as a hospital designed informed consent to make sure that all of the legal requirements have been fulfilled. The testing can be ordered online through a portal or on a paper requisition, whichever is easier for practices. Kits are supplied by the lab, and these include the blood tubes as well as prepaid shippers. Some labs have systems to identify which patients need prior authorization and have a system where they can send that information to a third party to submit the prior authorization to take that off of the office's plate, given that it has become quite a large burden. And most of these labs also have in place agreements where if insurance doesn't cover an expanded panel, that they will only bill for the carrier screening that's considered standard of care so that patients do not end up with large out-of-pocket payments. Results usually take about 2 to 3 weeks and are sent by fax or by email. And then at that point, partner reflex testing can be arranged if needed. This is just one example of what these reports look like and what they should look like. So we like to see on these reports a very clear indication of whether the patient was found to be negative for the conditions or high risk or carrier for any of the included conditions. We also like to see that the number of conditions is specified clearly on the report. So this is an example of a negative result for a patient who had a large 105 condition panel performed. We also like to see in the reports a list of what conditions were included, the residual risk. So you can see in this column, this was a sequencing-based test, so the residual carrier risk for all of the conditions is really quite low. For cystic fibrosis specifically, for this patient, it's 1 in 2,700, which is far lower than what can be achieved with a genotyping test. And then the reproductive risk, or the risk for an affected pregnancy, assuming a partner of similar ethnic background, is also listed. In a carrier, should be clearly identified, the conditions stated and the reproductive risk. So you can see for Smith-Lemli-Opitz syndrome, this condition has a carrier frequency of about 1 in 50, so a reproductive risk for a carrier of about 1 in 200. Also specified on these reports is what the specific change or variation in the gene that was identified. And this we use in genetic counseling to help estimate the predicted severity or form of the condition when there's a variable phenotype. And we also often find ourselves actually verifying that the variant was correctly interpreted. And we have found some errors in interpretation over the last few years. And then for individuals who have partner screening, so screening of both partners at the same time, or for patients who are found to be carriers of X-linked conditions, reports will state high reproductive risk and that 1 in 4 chance for an affected pregnancy. So some take-home points about carrier screening. Carrier screening should be offered to all patients prior to conception is best, and patients should feel comfortable declining the screening. Each practice should develop a standard approach, and we'd like to see that include some written information given to patients so that they can come into the visit feeling informed and able to make that decision. Pan-ethnic panels have many benefits, but they do also have some risks that need to be considered, and pre-test counseling is very important regarding those risks, as well as the potential benefits and limitations of a variety of different testing options. And I think, lastly, that more conditions does not necessarily equal better care, and that we need to be really thoughtful about what these panels include and sort of the impact they have on the pregnancy experience. So that completes our webinar, and we're happy to take any questions, and please reach out in the future if any questions arise.